Some surgeons have good days in Phaco, some surgeons have bad days in Phaco, and some surgeons have worse days in Phaco. So, this is the video of my Phaco surgery of bad days. Because NS4, it was around brown cataract, was patient was diabetic, and as you can see, the pupil was also it was mid dilated, and the patient was having low platelet count and was also in a blood thinner agent, so it was impossible to give her block. So I decided to do the phaco surgery in topical anesthesia. It was interesting to see that the patient was very cooperative initially, and she was not having any problem during the beginning of the surgery. So I stained the nucleus, stained the intercapsule as always, and after washing out the stain by VSS and followed by putting viscoelastic substance forming the AC. I noticed that the pupil's diameter was came to 4 mm, but after inflating the uh, antechamber with visco, the pupil diameter was increased to around 5 mm. So after uh, forming the AC with visco, I decided to go for capsular axis. So I put repositor on the left side and the axis in the right side. I started doing the capsular axis, and uh, what I saw that since the diameter was around 5 mm, so I was going slightly larger than 5, around 5.5 mm on capsular axis. Uh, and I was doing it very slowly. I was not intending to do the extension of the axis, and so in frequent interval I was inserting the visco in the antechamber to form the AC, and uh, somehow slowly uh, I was finishing the axis. I didn't use any pupillary expansion device because of two reasons. It was not available at the time in OT, and the patient was very poor. Somehow they were agreed for undergoing having hydrophobic lens implantation. So after again forming the AC with visco and finishing the axis, I didn't go for the main wound incision. So it was little posterior limbal approach. And I made it a triplanar incision. And so it was when the brown cataract. What problem I was having is that I was not getting able to see the posterior capsule. So when I was doing the Rexis, uh, I I was not seeing any fluid web, but so that's why I was doing multiple hydrodissection and uh, to confirm at least fluid web will there. So after again forming the antechamber viscoelastic substance, I decided to rotate the nucleus with the dialer, and when I was rotating the nucleus, it was rotating fine. So that surely signifies that the hydrodissection was good. And now it came for the phacoemulsification. Now I was using low-rate phaco machine. So prior to insertion of the probe, I adjusted the probe in the lower sleeve. So since I was using the lower phaco machine, my power was for trenching was 50. I was planning for divide and conquer. Now since it's a hard cataract, so what mistake I done that I should have used the dialer to hold the nucleus at periphery so that the nucleus becomes stable and it becomes easily for doing the divide, the trenching. But I was not doing it. Instead of that, I was doing trenching mainly superficially. And once I saw that trenching was around 20% trenching was done, I decided to rotate it and doing the procedure of divide and conquer. And uh, yeah, it was very the trenching depth was also not so deep, and also the trenching length was also very small. And I was thinking that it will be far enough. And more I was doing the trenching, my foot position was more I was leaving the trenching, my foot position was on came to zero, and the people become more small. So when I was doing the trenching in the main side, I thought it's enough trenching, so I can divide it, I can crack it. But it's a hard cataract, so it's become impossible for me to crack the nucleus. So I again started for doing the plus sign. But as I noticed, the pupil size becomes more and more small, and the plus sign what I made was also very small, and it was really impossible for me to crack the nucleus. And more I manipulate, I was getting in fear that it may uh, injure the jonules or causes PC rupture. So what I did, I lifted the nucleus on one side and decided to do the cracking of the nucleus in the AC. And but it was getting a little difficult because, as you can see, my power was very less. And also in Phaco and chop mode also, my power was around 40 and vacuum was around 310. So I should have raised it, but I decided to continue with it. So after putting Visco, I inserted the dialer, and uh, I put one half of the nucleus in the AC, another half in the bag, and I decided to go for Phaco chop then. But what I was planning is that I will do chop, and I'll do the cracking of the nucleus by putting the dialer in the back of the nucleus and do counter traction to crack it. But it was getting very difficult for me, and I was feeling a little problem for it. I again my dialer was not holding the nucleus properly. So what happened that in this some hook and crook maneuver, the entire nucleus came in the AC, and so I decided to do it very slowly, very slowly. Slowly, I decided to crack the nucleus in the AC, and very slowly, slowly, I decided to do the Phaco in the AC. So as I was applying more Phaco energy in the AC, the pupillary position was not in the primary. Also, the pupil was uh, deviated down, and it was not in the primary gaze. So I was having fear that it may injure the PC. So so with that respect, I was uh, doing the Phaco very slowly. But in terms I was putting the visco in the AC also in frequent interval, so that least injury of the endothelium occurs. And uh, again, since it was a very hard cataract and the fibers were in hard cataracts are hard to break, but that's why it took me a lot of time and a lot of energy to break it. But then I came to notice that the peripheral part of the nucleus was got emulsified, but the central part, which is hard to break, was taking time because of this fibers present in the dense cataract. But very slowly, slowly, I was emulsifying it, and ray of hope came when I saw the PC, the intact PC with no general dialysis. And on emulsifying the last piece, I came in the epinuclear mode where my power was very less. I should have increased it, but I uh, reduced my power to around 20 with a vacuum of around 310. And somehow the Phaco was over. So since it was a brown cataract, so I was not hoping any cortex should be present here. But then again, I decided to go for irrigation aspiration to verify whether there is a cortex or not. So I inserted the coaxial eye probe, and since the pupil was small, so I was feeling difficult to do the cortical aspiration. So what I did, I took again the dialer, and I was retracting the iris to see any cortex in there. And one cortex I noticed, cortical matter I noticed in superior part, and few were noticed in the nasal part. So yeah, few cortical materials were there, and uh, very slowly I was doing the cortical aspiration. And then I noticed one small cortical material was there in the subincisional part. So I decided to remove it later. So I was doing polishing instead of the posterior capsule, followed by polishing under the rexus margin. And once the entire polishing was happened, I decided to insert the lens. So since the hydrophobic lens, so I it was preloaded hydrophobic lens. So I enlarged my wound a little bit, and with the 2.8 keratom, so that it won't be difficult for injector to get inserted in the wound. Prior to insert the injector, initially it hurt, it slipped the epithelium and caused some epithelial defect, but it was noticed later on. So I was injecting the lens by screwdriver technique, and I was doing it very slowly, uh, because not to uh, do further more damage of the capsule or bag. And the lens was, thankfully it was on the bag, and then it was final viscovas. So as I told earlier, I noticed some cortical matter in the subincisional part. So where I took the repositor, and then I by using rock and roll technique, I was removing the visco, and then I noticed, yeah, one cortical splitter was there in subincisional part, and very slowly I removed it, and there was no further cortex or uh, visco was present. And after cleaning entire cortex and visco, I do the further last polishing wash. And after cleaning entire part, now I decided to close the case. So when I was closing the main wound, then I noticed that there's a superficial epithelial defect in there in the main wound. And what I did, I just simply uh, reposited it back with the help of the blunt part of the cannula. And after that, after sealing the main wound, I was uh, about to seal the side ports. And after sealing the two side ports, after sealing the one side port, then I uh, sealed the the second side port. And after sealing the second side port, the AC was well formed, no problem was that. But the epithelium, as you can see, the main port epithelium was little uh, eroded. So I reposited back, and the case was closed. And uh, since so the day one post-op was very bad. It was dense corneal edema. So I started with hypersol, and post-op 1 week the cornea was fine and vision was great. Thank you.